Yes. Today we have another opportunity and we have a proud privilege to organize this live webinar series, one of its kind with the Oncology Integrated Societies and Dr. Chaturvedi Cancer Hospital and Research Institute Private Limited. This is an institute which is 40 years old and we'll not talk much about it. We'll straight away talk about the topic for which we are today gathered here. So cancer ovary, everyone knows about it and everyone knows that it is so not so easily diagnosed as the breast cancer because that is external and this is inside the abdomen. So patients come to us in later stages because they can't find the difference between what is what. So I'll give the introduction to the topic. A woman has a risk of getting ovarian cancer during her lifetime in about 1 in 78. And chance of dying from this cancer is 1 in 108. This cancer mainly develops in older women. About half of the women who are diagnosed with liver cancer are 53 years old or more. The more in white than in black. The rate at which the women are diagnosed of ovarian cancer has been slowly falling over the past 20 years from 1 to 2% gradually in 1990 till now 3% per year till 2019. The records are available. This is because they use oral contraception to suppress the ovulation. The lesser the ovulation, the lesser the chances of getting ovarian cancer, and more the ovulation, more it is. During the half of the past century and decreased menopausal hormonal therapy use during 2000, both of which can lower the risk. Ovarian cancer mortality has declined 2% annually from 2000 and early 2010 to more than 3% annually till 2020, reflecting both decreased in incidence and an improved treatment. The improved treatments nowadays are good debulking surgery with high-tech techniques. For that, we have Dr. Shashank Chaudhary also with us. Today, he had posted a video. And for that, I had told him, okay, we'll play it in the last of the session. And but we had a talk with Dr. Piyush, who is a renowned personality and a medical oncologist. He will speak about the cancer stage 4. The topic and all that, Dr. Chaturvedi will tell. He is the proud owner of Dr. Chaturvedi Cancer Hospital Research Institute Private Limited. And he has been past president UPAORI. He has had many trainings abroad in LINAC, in brachytherapy, and many more. He has been co-guide. He has had many awards and publications to his credit. Over to you, Dr. A.K. Chaturvedi. Kindly tell us more about the speaker and his credits.
Thank you, Dr. Deepti. Thank you, Dr. Deepti.
Yeah, please continue.
Today we are here to discuss about the advanced ovarian cancer.
Just a minute, excuse me, sorry. We were going to play a video about our hospital. So, Prachi, will you please? Shreyasi.
Yes, ma'am. Yes, ma'am. Yeah, I'm playing the video.
Please play the video.
Yeah, sure.
It's just a few seconds video. Because ours was an old one, so it is having all old techniques and it's a very small video, but we are going to update it soon with the latest. Many things have been cut. Where is the radiotherapy unit in between?
Fine.
There was a radiotherapy unit also. Anyway.
Okay, fine.
Next time we'll get a good one.
So thank you, Dr. Deepti. Today we are here to discuss about advanced ovarian cancer. And we are lucky to have Dr. Piyush Vajpayee, MD DM ECMO, Certificate in Healthcare Management from Indian School of Business. He is a learned person. Dr. Vajpayee is heading Department of Medical Oncology at Manipur Hospital, Manipal Hospital, Delhi. He has done his MBBS from BRD Medical College, Gorakhpur, and then MD in Internal Medicine from GSBM Medical College, Kanpur. Then he pursued his super specialty training in medical oncology at Adyar Cancer Institute, Chennai, and was associated as faculty there. Now, he is in Delhi for more than 14 years. He is practicing there, and he has got vast clinical experience with treatment of carcinoma breast, gastrointestinal, gynecological cancer, and hemato-lymphoid malignancies. He also takes care of autologous transplant program in myeloma and lymphoma programs. He has a built interest in precision oncology, targeted therapies, and immunotherapies. He was part of several clinical trials as a principal investigator and co-principal investigator in several clinical trials in JIPMER, BLK, and Max Hospital, Delhi. So today he is going to speak on carcinoma ovary advanced stage, current management strategies, and role of precision medicine. Dr. Piyush Vajpayee, over to you.
Good evening, all, and thank you, Dr. Chaturvedi sir and Dr. Deepti ma'am. It's been an honor to speaking over here on this forum. So I'll just share my presentation, and I hope that's visible over there. My slides are visible.
Yes, yes. You may continue.
Yeah. So my topic over here is advanced stage carcinoma ovary and management strategies, and what is the role of precision medicine, which is coming up, especially in the management strategy currently in the upfront scenario. Since it's a very vast topic, I will try to stick to the advanced stage, as well as basically what management strategies have been there, and also what has come up in this advanced stage scenario. I would, my major part of the talk would be dedicated to high-grade serous ovarian carcinoma, because that's one of the major bulk of disease that we get to see. Nearly 2/3 of ovarian cancer patients fall into this category. So I would be talking in these particular headings: epidemiology and risk factors, pathology, approach to the patient, what about staging and surgery, and sort of both are actually interlinked. As you can see that staging is ovarian cancer staging is a surgical staging, chemotherapy, and where is precision medicine now in ovarian cancer in the upfront setting. I would not be delving into the relapse ovarian cancer. That would be another vast topic. However, I can take questions if in case there are any. So talking about new ovarian cancer cases as per the Globocan data, what we have from our cancer registries all over India. So we have nearly 26 cancer registries, public cancer registries all over India. And you have nearly 45,000 cases of ovarian cancer, as you see in the purple pie over there in that pie chart. So you have nearly 45,000 cases being diagnosed. And this is, as you can see, it's the female population. And this is the third largest pie over there that you can see as per the 2020 data. And you see the number of deaths amongst the new cases. So it's not amongst the new cases, but nearly 32,000 deaths happen. And so therefore, this is a disease which is probably because of its late presentation and tendency to relapse again and again, these number of deaths are there. And therefore, there's a huge need gap to actually prevent or keep the patient, preventing a relapse. So this what we see a 5-year prevalence scenario. It's nearly 1 lakh patients are present if we talk about 5-year prevalence. Now, talking about the histopathology, and 90% are actually from the epithelial origin. And then there are sex cord, stromal, germ cell, mixed cell type, and therefore their cell of origin is important. So it's upon the cell of origin that this classification is there. Talking about the epithelial ovarian cancer, which constitutes nearly 90% of ovarian cancers. So serous occupies the largest chunk, nearly 70% of the patient. Endometrioid, nearly 10%. Clear cell, again, a similar figure. Mucinous is a rare situation, 3%. But once you see a mucinous carcinoma, actually it's a very hard to chemo-resistant sort of carcinoma, and therefore a role of surgery is at most important over there. And also you need to actually check on the bowel as well as the appendix. Malignant Brenner tumor and mixed histologies occupy the rest of it. Amongst the serous, there is a low-grade serous carcinoma and high-grade serous carcinomas, which actually are there. And high-grade serous carcinoma is what we will be talking about today. So they have how they actually develop. It is from the different sites. You will see that the high-grade serous, it will develop from the fimbria. It will start from the fimbria of the fallopian tube, and therefore it will be actually the BRCA gene, which will be the driver gene, the TP53, which will be the driver gene. And therefore there are other gene patterns as well. So here the precision medicine is coming up, and therefore you have this these genomic classifiers, which are now also translating into immunohistochemistry classifiers, and you can actually differentiate between these subset of ovarian cancers by your immunohistochemistry as well. However, for high grade, you can see the BRCA1 and BRCA2 are also important. And then in the borderline serous, you have different markers, KRAS, BRAF, and PIK3CA being the driver mutations, or the most common ones over there. And if we talk about the mucinous, KRAS and HOXA11 is, as you can see in the chart. And also, if you see the ovarian, which is the clear cell or the endometrioid carcinoma, they can actually arise from endometriosis. So if there has been a history of endometriosis, you can get a clear cell or an endometrioid ovarian carcinoma. So if you get these carcinomas, you need to actually check the history of endometriosis, and you can actually check upon, or you should check upon, the MMR pathway. Though MMR pathway is now a marker which should be checked in every cancer, but here one should check for MMR pathway because you have a therapeutic option over there in form of immunotherapy. So talking more about high-grade serous ovarian carcinomas, and they actually are the most frequent ones, and as I said, they arise from the distal fallopian tube. That's the site of origin, especially in BRCA patients. In high-grade serous carcinoma, which are usually they are detected in a high grade, high stage, and no macroscopic residual disease is after debulking is one of the main prognostic variable. All show P53 mutation and genetic instability. BRCA genes are involved in hereditary and in some sporadic cases. So if you look at this particular chart, high grade is labeled as type 2 over there in ovarian carcinomas and constitutes 70%. And you see the major chunk is 95% of which these patients would present in advanced stage, more than stage 1. Only less than 5% you will find that they could probably present in an early stage. And survival is what you have over there on the chart in the early stage, stage 1. Basically, this is what you would have a survival. Risk factors for ovarian cancer. These are the known risk factors, and you have family history as one of them of ovarian cancer, of not only ovarian cancer, but if there is a family history of breast, uterine, or colorectal cancer, then you need to actually check upon the hereditary gene panel. You need to look for BRCA-like genes. Then menopausal status is also, age is also a related factor. So these factors actually increase the risk. And what decreases the risk, as what Dr. Deepti was telling, that the use of oral contraceptives, breastfeeding, and pregnancy, these factors are actually decreasing the risk of ovarian cancer. What about screening? So far, we know that ovarian cancer, unfortunately, the large study conducted at United Kingdom basically showed that with the tri-modality sort of testing, that is, you do a CA-125 or transvaginal sonogram, or you do a ultrasound screening or a transvaginal sonogram in the second line. So you will not get any difference in deaths due to ovarian or tubal cancer. So either you do no screening or you do active screening in the general population. And here nearly 2 lakh patients were actually, screened, not patients, but the general population was screened, because this is general population, which is not at high risk for ovarian cancer, 50 to 74 years, not at high risk as in they are not genetically predisposed. So they weren't selected likewise. So you did not find any great benefit in screening. What leads to late presentation is the vague symptoms of this particular malignancy. So the common symptoms are usually very non-specific. A patient could present with a feeling of feeling of early satiety, pain in the lower abdomen, bloating, or probably just a need for more urgent or frequent urination. There would be some very other non-specific symptoms as well as listed in the box. So basically, for these, patient could end up in taking some over-the-counter antacid pills, or could be taking, could be going to the gastroenterologist. So very non-specific symptoms. The patient could be going to the GP, and the GP would probably start with a course of probably antacids. So this is how it presents. And even in ultrasound, you might not catch up if it's an early stage situation. So that's why basically these are non-specific symptoms. But by the time these symptoms start coming, of course, you have a voluminous disease. So when you find these symptoms, when the physician would find these symptoms, or the gynec would find these symptoms, there could be an ovarian mass. And the next thing which comes into the gynecologist's mind is, if it's just an ovarian mass and there is no ascites, so let's say it's an early situation, then whether it's a cancer or whether it's a situation of, just a benign tumor or a benign cyst. So there comes the role of these particular algorithms, the RMI, which is a risk of malignancy index, which is calculated on the basis of CA-125, TB-US findings, menopausal status, and then Roma index, which actually utilizes a more sensitive HE4, basically, this particular protein, which is having more sensitivity and specificity for ovarian cancer. So a Roma index of more than 4 actually increases the sensitivity to 93% and specificity of 70%. CA-125 alone can be very confusing. So it can be raised in various other possibilities. So you can have, non-gynecological causes over there, as you can see, liver cirrhosis, pancreatitis. These days NFLD is very common, fatty liver. So there can be many non-specific causes. So RMI over there, as you can see the ultrasound score that, if these sort of multilocular cells with solid mural components, if these sort of findings are there, the RMI score goes up. And if it is more than 200, this is what is followed in UK specifically. And also we have adopted this in a lot of centers, so that more than 200 requires a specialist consultation. And at RMI of 200, 78% of ovarian cancer can be detected, and it is 87% accurate. Nonetheless, frozen section is still important at times, and therefore you need to take that aid also to rope in a surgical oncologist or gynec oncologist if in case it's positive. So talking about approach to the pre-treatment workup, CT scans are important to define the extent of disease. Imaging of the chest with CT should be undertaken to look at the chest as well as the pleura. MRI has no major space in most of the guidelines. And therefore, unless you have any pressing indication, then only MRI would come into picture. Otherwise, MRI is not a great modality in terms of following these patients up, because you need follow-up scans, and MRI is a very tedious scan to do in these patients. Reliance on cytological diagnosis. If it's just a slight preparation of cytology, please do not start chemotherapy on the presence of cytological diagnosis. One should avoid it. One should go for a cell block at least, or a peritoneal biopsy. Primary surgery remains the most common preferred approach, but we will discuss more about this. Where it is deemed not feasible, an image-guided or laparoscopic biopsy should be performed. So this is very important. So either you perform an image-guided biopsy, which most of the times you would be able to do so, or one can also take a laparoscopic biopsy approach. So staging, as we all know, and I'm sure, I do not need to go into the detail of staging. It is, I will just broadly run through. Stage 1 is tumor confined to the ovary or fallops. Stage 2 is tumor involving one or both the ovaries or fallopian tubes with pelvic extension or primary peritoneal cancer. And stage 3, when we talk about it, it's beyond the pelvis. So it's gone into the abdomen. To the retroperitoneum. So that's what is stage 3. And then, of course, distant metastasis, we classify in 4A or 4B. 4A is the one which is lesser sinister, that is pleural effusion with positive cytology. And 4B, of course, is the parenchymal metastasis in the visceral organs. So as you can see in the box on your right, most patients with, epithelial ovarian cancer, serous high grade, would present in stage 3 or 4. In stage 3, the disease involves one or both adnexa and spread to the abdominal peritoneum or to the retroperitoneal lymph nodes. So what is optimal cytoreductive surgery? We all talk about surgery in ovarian cancer. And so this is the photo of these two medical scientists, Dr. Berek and Dr. Hacker, and they published this particular paper and their book, basically. So we all have read this, and this is what all it started. That they showed that if it's less than 5 millimeter, the smaller the residue is, the better the survival was. So basically, cytoreductive surgery in ovarian cancer, all it boiled down that you are making the residue smaller. The surgeon is making the residue smaller. So aggressive surgeon, I mentioned that, aggressive surgeon makes the residue smaller and you have a better survival. So what does that mean? It means that is it the act of committing cytoreduction or the manner in which the disease grows? So is it an aggressive surgeon or the disease biology that permits the optimal debulking was the question. So the gold standard, which was realized in most patients with stage 3 metastatic, ovarian, fallopian tube and peritoneal carcinomas, was optimal cytoreductive surgery, which it was realized and has been realized over time requires appropriate surgical expertise. A surgeon who is doing a lot of gynec oncology surgeries, better performed at regional cancer centers. And what are the factors which would influence the maximum cytoreductive efforts? And you see the last point over there, the aggressiveness of the surgeon. So the more aggressive surgeon, the more aggressive, the more lengthier the more diligently performed surgery, long surgeries, cherry picking each small nodule, the better the outcome would be. So Other factors are also there: performance status of patient, biology of disease. In a nutshell, the other factors are basically the biology of the disease. So it again boils down to two things. To get a maximal cytoreductive effort, you should have one, a very experienced surgeon. Number two, the biology should be sort of better. It should not be a very bad disease. I will show you one photograph over there. So then what is the most optimal status? Less than 0.5 centimeter or 0. So now it has been accepted. Nothing should be visible after optimal cytoreduction, and therefore 0. It is going towards 0. So as you see from this particular paper, it was established that, if it is 0 millimeter, nothing's visible over there, then you have better survivals as compared to 1 to 10. Ovarian cancer surgery is a open surgery straight away, unless you are looking actually for biopsies. So then probably you can consider laparoscopy. Otherwise, when ovarian cancer surgery is the intent, then actually it's a open surgery. And given why is it an open surgery? Well, given the tumor biology, the way it spreads, and the surgeon needs to have a complete tactile and visual exploration of the abdomen, it is better to perform it in an open way. To avoid underdiagnosis of peritoneal and retroperitoneal spread and subsequent undertherapy, laparoscopic or robotic surgical staging cannot be recommended at this particular point. And also, to have basically a good view, you need good retractor systems, and therefore this is important. These sort of instruments are important, or the prerequisites once we are talking about advanced ovarian cancer surgeries. How aggressive should one go? So actually, surgeons, ovarian cancer surgeons, organic surgeons would go and take away the pelvic viscera, do colectomy, sigmoid colectomy. Lymphadenectomy is also very important. Sometimes small intestinal resections are there, splenectomy, diaphragmatic resection, hepatic resection, and pleuropulmonary resection. So you will have this from the Berwick and Hacker again, and you have, the sigmoid, the tumor is actually sticking to the sigmoid colon over there. And this is what is done. A part of sigmoid is actually removed and a reanastomosis is done. Lymphadenectomy is also important, has an important survival impact. So especially lymph nodes which are bulky, and especially at very precarious sites. So near the ureter, you need to actually go diligently pick out these lymph nodes, take out these lymph nodes. Important that again they form, doing no lymphadenectomy versus lymphadenectomy, there is a survival difference. Sometimes you get this sort of disease patterns, and this is, there in the infracolic omentum. So carcinomatosis. So you have this, and there, as you can see, the infracolic omentum over there, it's actually hanging just from the stomach, going up to the splenic hilum, as you can see. So if this all is involved, then you need to actually just take, and it's a part of the surgery. It's a part of the, extensive surgery. So you need to take out, and sometimes you end up actually taking out the spleen as well. Liver metastasis. Now, sometimes these are present and we think that these are parenchymal metastasis, but actually they are most of the time subcapsular metastasis just lying on the surface. So they need to be taken out. They cannot be left. So they have to be taken out. That's what is important in such a tedious surgery, such a long surgery. And that is how you can make an impact in the survival of the patient. Then this question was there that neoadjuvant or upfront strategy. So you had a meta-analysis of the randomized EORTC and the chorus. And you had the meta-analysis which showed that, around 1,200 patients taken in this advanced setting, and interval debulking was planned after 3 courses of chemotherapy. So that's allowed after 3 cycles, surgery was done. And it was found that, patients with stage 3C and metastasis less than 5 centimeter are generally better treated with primary debulking as long as their performance status or good medical condition is good, and there is no extensive spread on the bowel or tumor or inoperable sites. So that is around the superior mesenteric artery. Patients with stage 4 are generally better treated with neoadjuvant chemotherapy, except for those with pleural effusion only, and easily resectable stage 4 probably could again be considered for surgery. So this trial showed that, this meta-analysis showed that you can consider chemotherapy as a neoadjuvant strategy if in case the medical condition of the patient or there is extensive upper abdominal disease pattern. And when one is talking about starting chemotherapy, one should have a diagnosis because surgery has not yet been done. You are sort of unsure about the sort of disease pattern. Then these are the ways actually one can get the, differentiate between poorly differentiated carcinomas or malignancies. These sort of immunohistochemistries do help in differentiating, where PAX8 ERPR is there for endometrioid, and then PAX8 WT1 for high-grade serous. So these are certain immunohistochemistries which are required. So talking about chemotherapies, basically, so I would just take this later. So again, neoadjuvant, well, these are the scenarios that the surgeon would, refer to medical oncologist, or, a tumor board meeting could decide upon that here, chemotherapy, the boxes in yellow, the chemotherapy should proceed first and not surgery first. So these one should be aware that especially the upper abdominal disease, and for the lower abdomen, as you can see, the rectal and sigmoid diffuse serosal involvement, vascular side wall invasion, ureteric invasion. Talking about systemic chemotherapy, how the things progressed, how the things evolved. And basically, as you can see, right from ICON 2, which actually compared carboplatin and CAP, the median PFS was seen, and nearly similar median PFS with a single agent chemotherapy, carboplatin. Now, ICON 3 went on doublet, and therefore it was seen with paclitaxel carboplatin or versus platinum, there was slight improvement in PFS. With the triplet, basically, this was a single arm study. There was not much of an improvement in terms of numerical. Again, over 7 addition of topotecan, you did not find much of a difference in, adding the third agent over there. Likewise, for over 9 triplet. So another strategy which actually brought some interesting information, and that was a dose-dense strategy. So a dose-dense way of giving paclitaxel 80 mg per meter square, weekly basis, 6 cycles, and adding carboplatin once in 3 weeks was the way what Japanese tried. And they found that the median or overall survival was better in terms of dose-dense chemotherapy. And therefore, some centers, though there was another antagonizing trial for this, but then some centers have adopted, especially for patients who present with poor performance status. This is one of the standard of cares now in such patients. So, I mean, when we talk about ovarian cancer, high grade, stage 3, we talk about probably the chances of relapse would be 70 to 80%. And therefore, how to prevent this relapse becomes important, and how to sort of extend the relapse-free interval is also important. So you prevent a symptom from coming, or you can try to contain the disease, probably by actually drugging. The drug should be such that it should not cause side effects. Now, if we look at the initial strategy, of GOG 172, and here basically paclitaxel was given as a maintenance strategy, not a great way to actually, consider things. Then came ICON 7 study and GOG 218, where this bevacizumab was tried, and it was found that the median PFS was better, but overall survival benefit was not there. It was there in a subset of group where optimal cytoreductive surgery was not done, or it was a stage 4 disease. So these two trials basically did lead to a PFS benefit, and you have GOG 218 using 15 mg per kg of bevacizumab along with the paclitaxel carboplatin, and ICON 7 using 7.5 mg per kg of bevacizumab. In most of our practices, we use 7.5 mg per kg of bevacizumab along with paclitaxel carboplatin, and a total dose of nearly 18 cycles are given. So it was found in GOG 218 that the BRCA subset actually was doing better. Amongst all the subset, the BRCA subset was doing better. As you can see, the BRCA2 doing much better over there in terms of median PFS. So this led to something what we started calling as, hypothesizing towards genomic instability, which now has been realized as the hallmark of ovarian cancer. And therefore, genomic instability, when we talk about it, it refers to a high frequency of mutations within the genome of a cellular lineage. These mutations can include changes in nucleic acid sequences, chromosomal rearrangements, or aneuploidy. And basically, you have DNA repair mechanisms and DNA damage mechanisms. And if you have the DNA damage mechanisms overwhelmingly being there, in form of genetic instability because of some germline mutation, and the DNA damage repair mechanisms is at fault, then probably this can lead to the cancer cell apoptosis. And therefore, this is one way actually to look at synthetic lethality, which we call it. If in case there is a double standard base repair, which is done by the HRR gene. So if the BRCA is actually absent over there, and the PARP is the enzyme which is taking care of the DNA repair, and if you block the PARP, then basically the cell actually has nowhere to repair its DNA, which therefore would keep on accumulating errors, and therefore the cell would actually have apoptosis. So eventually, you look at this particular the outcome, the genomic instability. This leads to the cell death. What are the causes of genomic instability? You have obviously inability to repair the DNA as the cause. What is the cause of inability to repair the DNA is the homologous recombinant deficiency, HRD. And what actually is constituting HRD is BRCA1 and 2 mutation, the genetic mutation, and then there is promoter methylation. That is, we are talking about epigenomics then over here, and certain unidentified causes. So this all leads to HRD. And therefore, in such individual, the inability to repair DNA is there, and therefore a genomic scar is there. So what can the, how to look at this particular genomic scar? So when we ask for a BRCA1 and 2 mutation, we can actually check this by blood or by saliva. These other mutations are actually, when we take the help of NGS, then only we are able to detect these mutations. To detect HRD, you have specific panels, and this is done after actually looking at the wholesome genome, and then eventually identifying what actually is causing the genomic scarring. So HRD is basically a reflection of what the genomic scar is, eventually the reflection of what actually has happened before. So what actually causes? Well, this is tumor BRCA mutation, as I said. So you have other things as well: loss of heterozygosity, telomeric allelic imbalance, and large-scale transitions as a cause of genomic instability. So you have tumor BRCA mutation and genomic instability, which is because of these particular three causes, which will eventually lead to a score that you get out of 100. And a cutoff score by Myriad Diagnostics, one of the labs which actually does HRD, is around 42. And this sort of test otherwise is done in other labs, like Foundation One does it. And then there are other labs in India also which have started HRD testing. So when I'm talking about HRD, I'm talking about these particular steps. Again, I will go through. So we know blood germline BRCA testing. Now, in germline BRCA, in ovarian cancer, nearly 15% patients could have germline BRCA positivity. When we talk about tumor or somatic BRCA, so additional 5% will come. So if we talk about sending the tumor block, then we can catch up another 5%. If you look at other BRCA-like mutation, nearly another 20% will add, 15% will add up. And if we talk about looking at the HRD, that is the genomic scar eventually, which could be epigenomics also, there nearly half of the patients of ovarian cancer would fit in, and they will have genomic instability. So what actually brings in this synthetic lethality is these particular class of drugs called PARP inhibitors. They actually inhibit the PARP enzyme, which is the actual enzyme for non-homologous pathway, and it actually repairs the DNA. If you inhibit it, the only way to repair the DNA is lost, and the cell succumbs to cell death. So olaparib, verapamil, niraparib, and rucaparib are these particular drugs. Talazoparib is also there. So these are certain drugs at our disposal, the first and the fourth one. So talking about basically the role of these drugs in maintenance therapy. So in maintenance therapy, these are the certain trials, Solo 1, which actually looked at germline BRCA mutations, and it found a survival difference. GOG, the Paula 1, which actually added olaparib and bevacizumab, and it again found the survival difference. But the question over here is, in BRCA mutated cancers, do you additionally need to give bevacizumab? Well, if you look at the hazard ratio of Solo 1 and Paula 1, in the sort of subset which is actually getting olaparib only, you will find that the hazard ratios are quite similar. When we talk about HRD scarring with BRCA wild type, then actually, if we look at the hazard ratios, again with the only PARP inhibitors used, then you find the hazard ratios almost quite similar actually over here. But when we look upon the HRD positive population and the addition of bevacizumab, then actually we find that there is a lift in the survival curves when olaparib and bevacizumab are added together. So bevacizumab will help those patients of HRD positivity who are BRCA wild type. So to summarize, these days, when a patient of ovarian cancer is there, we get a biopsy when we are planning neoadjuvant chemotherapy, especially in advanced situations. And this biopsy block, we ask for HRD testing. We get this HRD test, and companies like AstraZeneca would actually do free of cost because they provide certain patient assistance programs, and therefore they give these coupons, and therefore you can get this HRD test done. And then after, you have strategized that you want to go for primary optimal surgery or neoadjuvant chemotherapy, you start with, either the surgery or chemotherapy. And when you add chemotherapy, let's say first over here, so if you have carboplatin or paclitaxel in the neoadjuvant setting, then if you would add it, I would not consider adding bevacizumab. I would rather just add paclitaxel carboplatin unless there is large volume ascites. I do add bevacizumab. And once, once the chemotherapy, once the surgery is done, then I would continue bevacizumab if in case bevacizumab was added earlier. Or otherwise, if in case the upfront surgery was done, then I would want to continue bevacizumab during chemotherapy and maintenance. And based on the HRD, I would want to actually go by these particular strategies. So if it is HRD positive, and bevacizumab is added, I would want to consider adding Paula by going by Paula 1 strategy. Especially if in case BRCA is not mutated, but HRD is positive. So if it is, let's say, HRD negative, I would just continue with bevacizumab. Well, if the bevacizumab has not been added and it is a BRCA mutated and HRD positive, I would want to add a PARP inhibitor as per these strategies, these trial strategies. And if it in case it's a HRD negative, add a PARP inhibitor or a clinical trial. So to conclude, high-grade serous ovarian carcinomas are most common subtypes of ovarian cancer, and nearly 15% are associated with BRCA mutated germline mutations, and 50% have a genomic scar. Optimal cytoreductive surgery is the best way forward to put, for surgery, and it should be performed by an experienced gynec oncologist or a surgical oncologist. Maintenance strategies have made survival better, so also the quality of life. And precision medicine is getting important in ovarian cancer space. So with this, I would stop and I can take questions. Thank you.
Thank you, Dr. Vajpayee. Such a nice talk. And it's really very nice to listen to you. Being a medical oncologist, you have explained everything what you want from the surgeons. That is more important, number one. Number two, you have to take out each and every visible metastasis rather than 0.5 centimeter or falana limca. They will not do. So this is another very good thing. And HRD, importance of HRD is very, very important. We must do the HRD testing, and accordingly you have to proceed for the chemotherapy. So that is very important. And you have explained everything in such a nutshell and in a very clear way. It's very nice. Thank you. Thank you, Dr. Piyush Bhatt. Any questions from the audience?
Yeah, Prachi will tell. Prachi? Shreya?
Yes, ma'am, I'm here. Yeah, let me check, ma'am.
Please paste. Because this is a faculty link, so they will only pay.
No, ma'am, we have not received any question yet.
All right, so let us only ask some questions to Dr. Piyush. Of course, your talk was very elaborative and informative, and thank you for enlightening us with so many more genetic testing like HRD. Till now, it was BRCA1, BRCA2, and all those things. So,
My pleasure, ma'am.
I'd like to ask you one thing. Like they say कि point less than 1 centimeter तक चलता है. अब ये zero residual carcinoma ovary during operation should be there. So is it possible 0 tak? Because something or the other will always be missed. Aggressive surgeon is there, definitely. but even they can't be so perfect.
Yes, ma'am.
कि जो मतलब your eye vision is also not so perfect.
Yeah. So if we look at this
Something or the other.
particular slide, ma'am, I will just go to this particular slide and no. So we have this study actually, which has shown that
Survival benefits, PFS
yeah.
is better.
So
Yeah.
we see that EFS was better. So you have 1 to 10 millimeter graph over there.
Very wide gap.
So this is a retrospective analysis, no doubt.
Okay.
And you rightly
Can't
said
this
that
be-
you rightly
can't
said
this
that
be- suppose you don't have, like in smaller setups, there are surgeons doing, I know, like
so
in Gorakhpur also, there are many surgeons doing ovarian surgery, and
Yes.
patients are going directly to them. That is
Yes.
what is our motto, to enlighten them that this has to be done.
yes, this has to be done.
Any rough surgery.
Yes.
But suppose it is done and they come to, like people like us, radiation oncologists, care or medical oncologists. So can we help?
So of
better
course,
survival?
so if we look at strategy of bevacizumab, where it actually helped better, was where the surgeon gave that insight that something probably could be left behind. Kuch reh gaya.
Yeah.
So if there, the attempt again should be made probably after 3 cycles to actually consider something more, in terms of surgical way. If in case the surgeon is really admitting and
Second look.
saying, yeah, so probably
Second look
after 3
surgery.
cycles, do a interval reduction strategy again. But yeah, so there are again some logistical issues, but then of course survival at the best has been seen better with the aggressive surgical outcome. There's no doubt about that. But bevacizumab probably, I would not say completely compensates, because the problem with bevacizumab is it is not showing a overall survival benefit in terms of a very robust survival benefit.
Medicine.
It is showing some overall survival benefit. Jahan par thoda sa kuch reh gaya, probably the overall survival benefit is coming over there, and therefore one can probably.
So which you think is the
you
better
can
for
go it, yeah. You can
You
go
see
ahead
the
and-
cost effectiveness. Cost effectiveness is also there with bevacizumab.
Yeah.
And
Yeah.
such a costly drug going for the 18 cycles and
Yeah.
having marginal benefit, that all counts.
Yeah.
Another very good thing which one must percolate in the public is that ovarian cancer, there is no shortcut. You
No
should not do any laparoscopic surgery or robotic surgery unless it is very small. That should be reserved only for the diagnostic tool, as a diagnostic tool, and go for the open surgery, because you need to
You
explore
have to do
each and
open
everything.
surgery only.
Yes.
I think so, even for biopsy, because if there are adhesions due to carcinoma, you will perforate the intestine instead of getting a proper biopsy, because first you have to put the trocar and the cannula, so that way, even after nitrous and all what you bloat the abdomen, still it can hurt due to adhesions. It can be brought into view. So I think
Absolutely.
open surgery for biopsy is the best choice. And in that only if you feel frozen section, but if it is not available, then you have to wait and watch. Second look, third look, फिर सब होना ही है. You can't help it. And then I have your friend, Dr. Piyush Bajpai.
Yes, ma'am.
Dr. I
Dr.
Khan.
Imran.
Yeah.
Yeah.
Khan.
Yeah.
He told
My
me
classmate,
that
yes.
He's
he
there.
wanted to. Yes, is he there? I think so. He is still there.
Hi there.
Yeah, I can see Imran.
Yes, Dr. Imran.
Yeah.
I
What
am
kind of-
actually very inspired by Imran, the way he has gone through, again, taking up another specialization. Very
Yeah.
inspiring.
Rare and
After
good
anesthesia and
anesthesia. Yeah, but after that he did PSM, I think so.
and that's what I'm saying, ma'am, that again, he did that, and hats off.
He is a good friend. We all meet every 9 and all. And now he's in view. Yes, you can go ahead with your memories. Sweet.
यस बहुत अच्छा लग रहा है कि हमारा एक बैचमेट इतने अच्छे टॉपिक पे यहाँ पे डिस्कशन हुआ है। और इसके बारे में जैसे कि मैं बेसिकली पहले एनेस्थेसियोलॉजिस्ट हूँ, उसके बाद अब मैं स्विच ओवर कर रहा हूँ पब्लिक हेल्थ एक्सपर्ट की तरफ। और इवन मैंने तो कुछ केसेस भी कराए हैं चतुर्वेदी सर के हॉस्पिटल पे, और ये लोग मैम और बहुत अच्छा काम कर रहे हैं, इवन बोथ इन पब्लिक एंड इन सोशल वर्क आल्सो। तो मुझे मैंने इनके यहाँ कुछ केसेस भी कराए हैं कैंसर रिलेटेड। अब जैसे कि मैं जो गायनेकोलॉजिस्ट है, सर्जन है, उनको बारे में जो उन्होंने कुछ मैसेज दिया उसके बारे में उसको हम थोड़ा बात करना चाहेंगे। जैसे कि इन्होंने बताया कि साइटोलॉजी बेस्ड हमें कोई डिसीजन नहीं लेना है, जो डिसीजन लेना है मेन वो बायोप्सी बेस्ड होना चाहिए। तो ये बड़ा इंपॉर्टेंट चीज है जो कि और बाकी डॉक्टर्स जो ट्रीट कर रहे हैं कैंसर पेशेंट्स को उनको देखना चाहिए। और जैसे इन्होंने बताया कि जो सीटी स्कैन है वो प्राइमरी मोडालिटी है, एमआरआई जो रिजर्व्ड है सम स्पेशल केसेस के लिए, तो हमें उस पर नहीं रन करना है कि एमआरआई करा लें। तो सीटी जो है हमें क्या उसका एक्सटेंट है वो सारी चीजें बेहतर बता देती है, हमें एमआरआई की बार बार जरूरत नहीं पड़ती है। और अब चूंकि स्टेरिलाइजेशन की चीज है, लेकिन ये कि हम जानते हैं कि अगर एपिडेमियोलॉजी देखें तो जो इस टाइम जो डेथ है वो मोर देन हाफ जो डेथ है वो नॉन कम्युनिकेबल डिजीज की वजह से हो रही है। तो उसमें एक बड़ा कंट्रीब्यूटर है कैंसर। तो कैंसर में कैंसर सर्विक्स और ये ओवेरियन कैंसर एक इंपॉर्टेंट कैंसर है, तो इसके बारे में डिस्कस करके बात करके और पब्लिक के पास जाना और इस तरह के इवेंट्स को ऑर्गेनाइज करके, ताकि जो हमारे जो ट्रीटिंग फिजिशियंस हैं, सर्जन्स हैं, वो लोग ज्यादा अवेयर हो सकें और पब्लिक से बात कर सकें, ताकि अगर वो एक शुरू के स्टेज पे अगर डायग्नोसिस हो जाएगी तो उसका ट्रीटमेंट ज्यादा अच्छा होगा और क्वालिटी ऑफ लाइफ हम बढ़ा सकते हैं। अब इन्हीं सब चीजों को देखते हुए पहले हमारे पास जो प्रोग्राम था NPCDCS के नाम से, अब वो रिसेंटली चेंज हो गया NPNCD के नाम से, नेशनल प्रोग्राम फॉर कंट्रोल ऑफ नॉन कम्युनिकेबल डिजीज। बाकी डॉक्टर पीयूष का प्रेजेंटेशन बहुत अच्छा था और हम लोगों ने चूंकि 5.5-6 साल साथ में गुजारे हैं बहुत सारी पुरानी यादें ताजा हो गई।
थैंक यू।
हम चाहेंगे शाइन करते रहें। थैंक यू।
So nice of you and so well summarized, better than me and better than any gynecologist. You are his real friend. That's why you grasped it so well. Anyway, thank you so much for being here just because of him. Thank you for taking my invitation. And now, can we
I think so.
play
There is a question. There is a question by one Dr. Preeti Yadav. Yeah, her question is, if scattered subcentimetric liver mets are there, more than 110 in number, and even after 4 to 5 cycles, how many more cycles can be given so that liver mets disappear for interval cytoreduction? So actually, the interval cytoreduction needs to be done after 3 cycles. Then whatever the number of mets or the residual disease is there, you need to actually address this. So irrespective of what the disease would be, attempt to optimally cytoreduce is done. And despite that, if in case there is a residue, then unfortunately, most of the times these liver residues could be subcapsular and therefore they could be resected. But if in case you could not still do it, then unfortunately it's the biology of the disease which is dictating, and then you'll have to actually look at medical therapies to give a high-end palliation.
Yes, very rightly said. Bevacizumab, olarimab, whatever is the new drug. For that we have the medical oncologist, and for that super specialty is there. So multidisciplinary treatment of cancer ovary is an important aspect in the better survival of all the cancer patients. So we have a surgical video from Dr. Shashank Chaudhary, who is MCH oncosurgeon. He just posted to me in the morning. Prachi, do you have it? Shreya?
Yes, ma'am.
Hello?
Yes, ma'am.
I told you to play that also.
Okay, so yes, ma'am. I'm playing the second slide of the video. Yeah.
Okay. Actually, it is more fresh.
Is there any issue,
Yes,
ma'am?
Dr. Shashank? No issue now. It's okay.
Okay.
Dr. Shashank, are you there?
Hello, ma'am. Hello, ma'am.
It
There was
was
a very
a
nice
very
video.
nice video. Yeah. Just give a short, brief introduction about yourself. You're working in
Sir,
Sahara, I think.
yes, I am working in Sahara. I have completed my MC Surgical Oncology from KGMU Lucknow and MS from GSVM Kanpur. And I'm in Sahara Hospital working as MC Surgical Oncologist. So this is I think I have started just HIPEC. This is my first surgery in private hospital. HIPEC surgery. This was a case of CA ovary post 3 cycle of chemotherapy. Initially, this patient was having gross ascites, peritoneal or mental nodules, subcapsular liver deposits. After 3 cycle of chemotherapy by the medical oncologist, the PET scan was done. So there was just left adnexal mass. It was also not FDG avid. It was just there was a mass, but it was not FDG avid. So I planned for a HIPEC in this patient. So the patient recovered well from this. It was very good.
The full form of HIPEC is
Ma'am, this is a
hypothermic
hypothermic intraperitoneal chemotherapy is given at
with
41
chemotherapy. Which
at the
chemotherapy?
41 to 42 degrees Celsius. It can be, ma'am, cisplatin or carboplatin. Yes, ma'am. Generally, in case of C ovary, we use cisplatin, and if in case other just like pseudomyxoma peritoni or any other else, then we can use mitomycin C also or carboplatin. So we have Dr. Gaurav Gupta was there. He was a medical oncologist in Lucknow.
We are having
So
his talk tomorrow.
so
Yeah.
So Gaurav and me were batchmates in Kanpur.
India
ESVM. No, so we did our
Achha.
MD medicine together.
Then you have to
Okay,
be
sir, okay.
there tomorrow also.
I was speaking to him actually yesterday evening.
Yeah,
And he told me
He
that
was there in
yeah.
this. He was there in this surgery. I have called him for for giving chemotherapy in this patient.
Yeah.
So just because Gaurav Gupta sir, he was my school senior. He's from basically he's from Raebareli. I'm also from Raebareli. Yeah.
कहाँ
Right.
फिर चलो अच्छा है
So
लिंक जुड़ जाता है
तो इस वाले केस में सर फिर I have done complete total peritoniectomy. Apart from this, I have done also pelvic lymph node dissection, total lumpectomy, and let's see what the future of this patient.
Future that is only uncertain. लेकिन people accept it. मुझे लगता I think so. First you have to give.
Ma'am, I have done a lot of
chemotherapy,
CRS.
Then first chemotherapy, then CRS with HIPEC, and then followed by again chemo or neoadjuvant, whatever you say, the new
Generally,
drugs.
yes, ma'am.
Yeah, after the
Basically,
test of
in stage 3, in stage 4, we have to go for a neoadjuvant chemotherapy. If in case the patient is also having ascites or multiple retroperitoneal lymph nodes, then we have to go
as
for a
doctor has
chemotherapy.
said, HRD also should be tested. HRD, डॉक्टर साहब ये एक और क्वेश्चन मेरा है डॉक्टर पीयूष ये आप बोल रहे थे अभी there is a company called
AstraZeneca जो है they're giving this
for free.
They're giving these coupons, test coupons.
No, they are doing it in only your hospital or everywhere.
No, this is
they are providing, they have got a scheme for
everywhere,
it.
ma'am, everywhere.
Huh?
So they would give everywhere.
Everywhere they are having
Everywhere.
a scheme. Everywhere,
Okay.
wherever you are
Okay.
using.
So,
They
So
get
we
you.
will also do it.
so
Yeah.
I have utilized it for a patient in SRMS also. So they're doing it everywhere.
Yeah. Dr. Saab is a visitor to SRMS Bareilly, where my daughter is also still doing SRship. She's very junior to him. Thank you so much. I am so happy to see you. And I just couldn't correlate Bareilly and you and BRD. Everything is so Delhi, kahan, BRD or फिर Bareilly. Acha, good links are there. Joining.
Very
So
nice. He has done
Thank you.
very good job for that.
Very
बरेली से
nice.
मेरा भी
Consolidated job. और आपकी सर्जरी भी
बरेली
बहुत
से
बढ़िया है
मेरा
सौरभ। हाँ।
Thank you, sir. Thank
बरेली
you.
से
हाँ।
मेरा लिंक ऐसे है कि एक
शशांक,
कॉन्फ्रेंस में
Sorry,
शशांक है।
Shashank, not Saurabh. Shashank.
Shashank Chaudhary.
हाँ, Right.
Hmm.
Good.
That
Sir,
we get to
this
know
was the
each
first
other
time
well.
first time in stage 3 I've used hypec. Otherwise, I was doing just total paternectomy, omentectomy, and just because this patient was affordable, so I have explained him about the hypec. We can go for a hypec in this
So
patient.
you have put cisplatin or mitomycin?
Sir, we have put cisplatin.
Cisplatin.
Yes, sir.
That's good. Good.
Since I have given the cisplatin was given in half doses, 45 in first hour, then 45 in another hour for 60 minutes in this patient. Because in PET scan there was no residual disease. There was just a bulky, mildly non-avid disease. And after the biopsy also came out to be that there was few calcification, and there were also not 1 or 2 nodes were positive, and everything was normal. There was not after total peritoneum was even normal in this patient after the chemotherapy.
Let us wait for.
I think that this will be
the
a great
result.
for the patient, because I have given also intraperitoneal chemotherapy, so it is more aggressive. I think I have done for this patient.
No, it's okay. 45
Very
milligram twice. That's good.
Mhm.
Patient will tolerate. No problem with
Yes,
that.
sir.
So
So
you passed
let
out
us
from
conclude.
KGMC?
Sir, I have passed out from KGMC in 2020.
Then Kampur.
Once I have come to you,
Avinash
sir.
Reddy is here. Dr. Avinash is here. इधर आइए. He is visited.
चैम्बर में है. आज भी सर्जरी की है ना वो.
Hi sir, congrats.
Hello, thank you, Avinash.
हाँ,
आज तुम हैदराबाद नहीं गए?
surgery.
सर आपका फर्स्ट है सर KGMC से हाइपेक करने वाले.
हाँ, first है.
First हाइपेक surgeon from Lucknow and from KGMC
From
also.
KGMC.
Congrats.
Dr. Reddy is also onco surgeon and he's
He's my
a
junior.
very
He knows it.
मेरा सीनियर है सर, बॉस है मेरा. उन्हीं के साथ देख लिया हमने.
Oh, so good.
उन्हीं
But
हमको
we
दिखाया
feel,
पकड़ के हाथ स्टार्ट
whatever
किया हर
it
एक
is,
चीज में.
he is really a very good surgeon. कितनी complicated oral surgeries मैंने देखी है, he handles so well. आप
सर
लोग
का ही होगा सर, शशांक सर का ये उन्हीं से सीख लिया.
Avinash is very good.
Very good. Because this
ऐसा
I've
कुछ नहीं.
seen practically, so I can tell, I can better
सर आप
comment.
वीडियो तो भेजना है सर, जस्ट फोटो नहीं चलेगा, आपका पूरा सर्जरी का वीडियो भेजना है.
हाँ, मैं भेजता हूँ.
वीडियो है ना मेरे पास.
अपने मीटिंग में उसमें.
और ये काफी बड़ा, ये तो शॉर्ट किया है मैंने इसमें.
So you send a good one. We'll post
Yes,
it in
ma'am.
our oncology group.
Okay.
And I will like to ask Dr. Irfan Khan. Listening to me or not? आपके national program में हम लोग जुड़ना चाहते हैं. Like I want to do, I'm doing every Tuesday cervical cancer screening, pap smear and all that. So you can put my post in your group, in your national programs कि हम लोग comment के लिए कर रहे हैं. So you can add. So it will be real pleasure.
इनको blood देना
Thank you so much. So let us leave for today.
Okay, ma'am. Thank you, ma'am.
Thank you all. Thank you.
Thank you
Dr.
for
Thank you,
giving
sir.
such a nice talk. Thank you, Imran.
Thank you, sir.
Thank you, everyone. Thank you for
Thank you,
extending us
Shreyas.
the opportunity to host the session. And I hope you had an amazing experience too.
Yeah, thank you,
Yes,
Planet.
sir. Thank you.
Thank you so much.
Platform for doctors.
Okay,
Thanks
bye.
for
Good night.
technical support. Okay, good night all.
Thank
Bye,
you so
good night.
much. Good night.
ये सब
Right.
बढ़िया रहा।